So this one is a location, inpatient hospital, but again, we're coding for the surgeon, right? So the location that it's inpatient doesn't mean we're going to code PCS. The hospital coder that's coding the inpatient case would code PCS, right? Because that's the hospital side. We're coding for the physician side, the surgeon. So we're coding for CPT for the procedure, not PCS. So here our pre-op and post-op diagnoses are listed together because they're the same. Our first one is bilateral mammary hypertrophy and hyperplasia, bilateral mammary ptosis, back pain unrelated to the breast, and neck pain unrelated to the breast. And that's important because if this had just said back pain and neck pain, how many of you guys have heard of patients with a mammary hypertrophy, and that's the biggest reason they're getting a breast reduction is because of the back pain and the neck pain, right? So those are signs and symptoms of bilateral mammary hypertrophy, and we would not be coding those if they did not say unrelated to the breast, okay? But in this case, we can code them because they're not part of the hypertrophy and the hyperplasia, which is really big breasts, right? This patient needs a breast reduction because there's just too much weight there. So our procedure performed is a bilateral reduction mammoplasty using an inferior pedicle technique. They took 800 grams from the right side and 900 grams from the left side. And if you guys think about it, there's 454 grams in a pound, right? So that's almost 2 pounds off each side. That's a lot of weight, okay? So anesthesia, again, we're not coding for the anesthesia. We're not the anesthesiologist. That anesthesiologist coder is who would code for this general anesthesia. As a surgery coder, we know our patient was anesthetized, so we're not coding that. Surgical findings state the breasts were predominantly granular, being about 75% very firm, fibrous glandular tissue interspersed with 25% fat. The patient has interscapular back pain and neck pain, which she has had for several years. This has become progressively severe and is not relieved by the usual measures. It is felt that the back pain is caused by her large and pendulous breasts with regard to her body habitus. And then the description of the procedure. In accordance with the pre-operatively marked new nipple site, we marked out an inferior pedicle breast pattern and instilled about 75 cc's of tumescent solution into the right side of the breast. The solution was prepared with 25 cc's of 2% xylocaine and 1 cc of 1 and 1,000 epinephrine plus 3 cc's of the sodium bicarbonate added to 1,000 cc's Ringer's lactate. And I'm sorry, the bottom of my screen has my WebEx controls and I can't see what's right there until I get to was something leaving about 1.5 centimeter of de-epithelialized stalk above the areola. So let's go. I'm trying to scan to see if I can get rid of this. Let me see if I can read it this way. I can't. Okay, sorry guys, I can't see what is in the last couple sentences. My WebEx control meetings are there. So with this, we know that we're doing this bilateral reduction mammoplasty. I'm going to see if I can just bring it up and share my screen. That might be easier. Okay. Hopefully you guys can see this instead of putting it on the screens. Okay, so let's go to the next page. So the new areolar site and the areolar size were planned using the 45 millimeter cookie cutter marker as a guide. The 3, 6, 9, and 12 o'clock positions were marked on the new areolar window and on the areola itself. The vertical stalk having been de-epithelialized, deep dissection was started at the 12 o'clock position and came towards the 3 o'clock between the upper end of the vertical limb and the medial flap. At the caudal edge of the medial flap, we began to bevel away from the vertical limb and connected this with an incision in the inframammary area at the level of the pectoralis major fascia. The incision of the caudal edge of the medial flap was beveled in such a way to leave about 2 centimeters of thickness on the flap, and the incision between the upper part of the vertical limb and the medial flap was not carried down deeply into the tissue, leaving some granular tissue connected with the central stalk. After resection of the medial triangle, deep dissection then started at the 12 o'clock position and came towards the 9 o'clock position, coming between the upper end of the vertical limb and the lateral flap, but not going deeply into the space between the lateral flap and the vertical limb. In other words, we left some granular tissue attached to the central stalk. We then connected this with an incision at the inframammary level down to the pectoralis major fascia and began our dissection on the caudal edge of the lateral flap, leaving about 1.5 centimeters of thickness of the lateral flap. The superior triangle was then resected, but we attempted to leave this area also with much of the vertical stalk, which carried the nipple areola, and after resection of approximately 800 grams of tissue on the right side, we detached the dermis inferiorly at the vertical stalk and inset the lateral and medial flaps with subcuticular 3-0 monocryl sutures. We then used subcuticular 3-0 monocryl for key points on the areolar window, the vertical limb, and the inframammary limb. We used skin staples to better oppose the skin edge. Final weight on the right was about 800 grams. Okay, so this whole first paragraph was just them accessing the area that they were going to remove this extra breast tissue, okay? And then the second paragraph is when they're actually going directly to that tissue and removing it, right? We removed 800 grams. So that's only one breast. So now they're going to do the exact same thing on the left breast, probably. Let's go read and see. Then third paragraph down here, on the left side, we again made our junctional incisions and instilled about 125 cc's of tumescent solution at these sites along with the suture line. De-epithelialization of the vertical stalk was carried out. We then began our initial dissection at the 12 o'clock position and came towards the 9 o'clock position, coming between the upper end of the vertical stalk and the medial flap. We began to bevel away from the vertical limb at the caudal edge of the medial flap and connected this with an incision at the inframammary area at the level of the pectoralis major fascia. And then page 3, we also beveled underneath the medial flap in such a manner as to leave about 2 centimeters of thickness on the leading edge, but attempted to maintain continuity between the deeper tissue of the medial flap and the central vertical limb. On the lateral side, deep dissection started about 12 o'clock position and came towards the 3 o'clock position between the upper end of the vertical limb and the lateral flap, once again trying to maintain continuity of the deep tissue of the lateral flap with the vertical limb and beveling away from the vertical limb, starting at the caudal edge and to the lateral flap. After connecting this with an incision on the caudal edge of the lateral flap, we also included the tail of the spence in the dissection. On the right side, we also had included the tail of the spence in our lateral dissection. So right here, he's adding something that he forgot to say in the paragraph before when he was reducing the right breast, right? So he put it here, which is fine. And then our final paragraph, after resection of the lateral triangle, the dermis was detached at the vertical limb inferiorly, and we inset the lateral and medial flaps at the midpoint the vertical limb with a horizontal half mattress suture of 0 proline insetting the new areolar sides at the new window with subcuticular 3-0 monocryl and using 3-0 monocryl for the vertical limb. Subcuticular 3-0 monocryl was also used for the inframammary limb, and skin staples were used to better oppose the skin edges. Dressings consisted of Xeroform, Curlex, fluff, and a support bra, and an external ACE bandage. There were no complications. The estimated blood loss was 125 cc's. Sponge needle count were correct. The patient tolerated the procedure well. And then the path shows normal breast tissue. Okay, so all of this, if we start with page 1, this is the approach, right? They're getting everything ready in the description of the procedure here. They're getting the patient's breast ready for the tissue that they're going to excise. And then every paragraph, the surgeon is walking us through how they're getting to that tissue and how they're taking that tissue out, right? And then if we get to the last paragraph, then we're closing the patient up and making sure that the bandages are there, that the healing that needs to take place with the Xeroform and the Curlex fluffs are in place. So again, all of that is included. We don't code the incision, we don't code the closure, we don't code bandages or casting, you know, with a reduction. That's all included. What we're coding is the procedure that those things were used for. Okay, so if we go back to our main page, the procedure performed is the bilateral reduction mammoplasty. So that is what we're coding. That is our procedure. Everything that it took to get to that site, to remove the tissue from that site, and to close the patient back up is included in the procedure. Okay? And then our diagnoses are all listed here as well. So in real life, I would query this physician on the post-op diagnosis. Number 3, back pain unrelated to breast, because under the indications, it does say that the patient has had interscapular back pain and neck pain, which she has had for several years. And then it says it is felt that the back pain is caused by her large breasts. But up here, it says it's not related. So for the sake of the class, we're going to code it because it's listed as unrelated. But I'm just telling you, in real life, I would query that. I would query the physician to see if it is related to the breast or it is not related and point out that statement exactly. So we have 4 diagnoses in this case that we're going to code, right? We're going to code the hypertrophy, the ptosis, the back pain, and the neck pain. So if you guys open up your CM book, let's first code the hypertrophy. That's really the main reason that the patient's coming in, right, is because of these very large breasts. So in your index, our main term there is going to be the hypertrophy. So I'm on page 176. If we go to hypertrophy and then to breast, we see code N62. Right? So now let's flip in the tabular to N62 and verify that code. So page 838, and under N62, hypertrophy of breast, tells us gynecomastia, hypertrophy of breast not otherwise specified, and massive pubertal hypertrophy of breast. So that's the code we want, right? Hypertrophy of breast. So write down N62. And now let's go to our second diagnosis, which is ptosis. So go to P in your index. And under ptosis, we're going to go to breast, which gives us N64.81. And we have a dash. So there's an extra code there, right? An extra character that we need to add. So once we get to our index, to N64, so N64.81 doesn't have an additional character. I don't know why it has that hyphen in the book. That must be an error. Because if we look at N64.81, I'm on page 838, it says to add a fifth digit under N64.8, right, which we did with the 1 for ptosis. So N64.81 is a complete code. There isn't an additional character to add. So our second code is the N64.81. And now let's go to pain. So we can do the back pain and the neck pain. So our main term is pain. I'm on page 245. And I recommend when you have the same term with different sites to look up both while you're right there. So we're going to look at pain and then back and neck both while we're right here under the main term of pain. Yes, in the CM book. So pain is on page 245. Actually, it starts on page 244. Sorry. So back pain is on page 244 under pain and then back. I'm in column 3. And we see beside back M54.9. And then let's go to page 245 to find neck. So pain and the neck is M54.2. So we have M54.9 and M54.2. Now let's flip to our tabular and verify those codes. So 785 is the tabular. So back pain, the M54.2 is listed right there, the cervicalgia. Remember, cervic is just the medical term, so that's correct. We're going to code the M54.2. And then for back, it just has dorsalgia. Again, that's the correct medical term. So M54.9. So those two codes are what we want. So altogether, we have those 4 codes, N62, N64.81, M54.9, and M54.2. Okay, now let's take our CPT book and find our procedure, which was a mammoplasty, right? So go in the back of your CPT book, and we're going to go to mammoplasty. I'm on page 998, and under mammoplasty, it tells me to see mammoplasty. So make sure to go to mamma with an A instead of an O, which is right up above it. So page 998, in the second column there under mammoplasty, we have reduction, right? Augmentation would be to enlarge. Reduction would be to reduce. Our procedure was reducing the breast tissue. So we want reduction, which is code 19318. So now let's flip to that in the CPT book and verify that that code is what we want. Okay, 19318 on page 107 in the CPT book says reduction mammoplasty. That's what we want, right? And then remember, we always ask ourselves after we assign our CPT if we need a modifier. What do you guys think? Do we need a modifier in this case? Our code reads reduction mammoplasty. Does that tell the whole story? Right, a modifier helps explain our story in more detail. Does reduction mammoplasty tell the whole story? I'll give you a hint. If we look at the procedure performed, it says bilateral reduction mammoplasty. Right. So exactly, we need modifier 50, right, to show that it was bilaterally. The mammoplasty was done on both breasts. Now let's just say for fun that this was only done on the right breast. We would use the modifier RT to show the mammoplasty was just on the right breast. Or if it was just on the left breast, we'd use LT to show it was the left breast. But since it was done on both breasts, we're going to use 50, so we're telling the whole story of where the mammoplasty was done. It was done on both breasts, okay? So I will stop sharing my screen. Then we have our diagnosis in 62, in 64.81, in 54.9, and in 54.2. Okay.